I'm eating blueberries, let's quickly do SAAG. In a patient of ascites, if you subtract the albumin in the serum of the patient minus the albumin in the ascitic fluid tab, you will get something known as the serum albumin ascitic gradient. Now, if you subtract that and you get more than 1.1 grams per deciliter of albumin, that mostly indicates a transitive cause of ascites. Most importantly, if you have more than 1.1 gram per deciliter along with ascitic protein measured less than 2.5 grams per deciliter, it will most commonly portal hypertension. Could be due to liver cirrhosis, there could be congestive cardiac failure, there could be chronic constrictive pericarditis or restrictive cardiomyopathy also for that reason. All of these increasing the backflow to the liver and congestion. You can also think about Budd-Chiari syndrome. You have other congestive causes like nephrotic syndrome, myxedema, IVC obstruction, pericardial effusion. This was right-sided heart failure, by the way. Remember two extra things. We have hypoproteinemia with anemia, and we have Meigs syndrome. Now, this is what Meigs syndrome is. It's a triad of ascites plus benign ovarian tumor plus pleural effusion. Now, as you can already judge from this, transitive ascites is mostly because of increase in the hydrostatic pressure inside the vessels. We're mostly talking about the portal vein and the veins in the liver. If you're looking for abdominal malignancy or cirrhosis of the liver, then you will have to check for occult blood in the stool. If your SAAG ratio comes out to be less than 1.1, that indicates mostly an infection or inflammation. It's mostly peritonitis. It could be 4 types of peritonitis, either bacterial or TB or malignant or SBP. Other inflammatory causes could be pancreatic ascites. There's also something known as chylous ascites where we have chyle or lymph accumulating inside the ascitic fluid. Could be seen in tuberculosis, malignancy, trauma, nephrotic syndrome. But more easy to remember for that is thoracic duct injury or obstruction. And then you have your classic blood cell cancers, which will also give rise to inflammation. Now, if any patient of ascites comes to you, will like to do a CBC, ESR, TLC, DLC. If you get a high ESR on neutrophilia, you will suspect all are infectious causes. If you want to rule out nephrotic syndrome, you can check for urine protein. In nephrotic syndrome and myxedema, you will have serum cholesterol high. In nephrotic syndrome, cirrhosis, hypoproteinemia with anemia, and in protein-losing enteropathy, you will get low serum albumin, basically low serum plasma proteins. Mainly the most accurate way to detect how much ascites you have is USG. If you're suspecting infection, you can actually take the ascitic fluid and you can send it for cultures also. We know that the patient has a problem just based on him having ascites. If you get it less than 1.1, that basically indicates that the ascitic albumin content is more. That means the ascitic fluid has got more proteins in it, which indicates more inflammation, infection, and all these causes in ascitic fluid. I hope you got the basic gist. Now, interesting thing is that if you manage this patient properly, around 500 to 700 ml of that ascitic fluid can be mobilized within a period of 24 hours. Just restrict your water intake up to 1 liter. Your sodium intake should be up to 200 mg. You give diuretics. Spironolactone can be given 25 mg thrice a day. If that does not work, we can also give furosemide. Now, before invasive methods, just remember that you have to keep monitoring the patient. Where it's going, so you will have weight loss. Monitor that. Be careful that it's not very rapid weight loss because your effective circulating volume has to be maintained too. That's why when we are doing abdominal paracentesis also, for example, in a cirrhotic patient, we can remove up to 3 to 5 liters in one sitting. So to prevent loss of circulation, we replace every 1 liter of ascitic fluid with dextran or hemacell. Treat the underlying cause. You do the Levine shunt from the peritoneum to the IJV. In resistant ascites, you'll have to do TIPS or transplant.